Hello and welcome to Single Pair Radio. I'm Paul Hoppe, broadcasting from the Hayburn Building in Louisville on the WFMP 106.5 Forward Radio Community Network, where news, information, and entertainment is available 24 hours a day, 7 days a week. The views and opinions expressed on our show are those of the speakers and not the station. Single Pair Radio is a project of Kentuckians for Single Pair Healthcare in conjunction with Physicians for a National Health Program through its Kentucky chapter. We produce this program because we believe healthcare is a human right. We advocate for a national, not-for-profit, publicly funded, single-payer healthcare system, also known as Enhanced Medicare for All, covering dental, vision, hearing, prescriptions, mental health, and long-term care, covering everyone starting at birth. Catch our programs at 2 p.m. Monday, 7 a.m. Tuesday, and 11 a.m. on Wednesday. We also stream our show on SoundCloud, Apple Podcasts, and others, so you can listen anytime. And remember, this is an all-volunteer radio station and relies on your ideas and donations to keep us on the air. Today, Doctors Mike Flynn and Gene Shivrly join me as co-hosts with their special guest. Let's get started. Dr. Flynn?
All right, well, thank you, Paul. This is Michael Flynn. I'm a retired surgical oncologist from the University of Louisville Surgery Department. Let me begin with the usual disclaimer that any comments I make during this program represent my personal views and do not represent the views of the Department of Surgery or the University of Louisville. Gene?
I'm Eugene Shivrly. I'm a retired rural surgeon from Campbellsville, Kentucky. Any comments I make do not reflect those of Taylor Regional Hospital or the University of Louisville Department of Surgery or the university in general. They're my personal comments.
All right. We have a special guest today who I will introduce in just a moment. Our topic today is a public option, and I confess I've been retired for a number of years and I didn't know very much about it. And doing some research for this program, I realized how confusing this whole public option is and different things in different places. And so our special guest is going to talk about that. We also will discuss some of the other issues facing our dysfunctional healthcare system. So our guest today is Adam Gaffney. Adam is an assistant professor of medicine at Harvard Medical School. He got his medical degree at New York University, an MPH at Harvard. He's a member of Physicians for a National Health Program and an advocate for Medicare for All. And as our listeners know, our program, Single Payer Radio, is sponsored by the Kentuckians for Single Payer. So, Adam, as we've done with guests in the past, we're going to give you an opportunity to make whatever comments you'd like to make for as long as you'd like to make them. And Gene will begin with the first question. I would challenge our listeners that there are a number of sources that they can go to double check the comments that we're making and double check our facts. The New England Journal of Medicine, the Journal of the American Medical Association, Wikipedia. They can just go on to Google and put in either Medicare for All or public option, and we'll have a bunch of sources that they can look at. So, Adam, the floor is yours.
Great. Well, thank you first off for having me. Since everyone else made just disclaimers, I will also say that what I'm saying is my personal views and not a reflection of my affiliations or employers. So I think the way I like to initially talk about Medicare for All and why we need it is to just succinctly outline what are the problems we need to solve. If you can't say clearly what the problems are that you need to solve, then it's hard to make the claim that one solution is better than another. What are the problems that we need to address in American healthcare today? And these, I will lay them out, and each of them are critically important. Number one, I think most people agree on, but not all policy solutions will actually address, and that's to cover the entirety of the population. And when I say cover everyone, I don't mean getting to where Massachusetts is. Okay, Massachusetts has 3% on insurance, and that may sound good, and that's better than higher rates. Don't get me wrong, but the reality is that that's far too many people slipping between the cracks. A, and B, it understates the problem, because those sort of figures are the number uninsured at any given moment of time. But if you follow people over time, far more will actually experience lapses in coverage, whether because they lose a job, whether because they find the options unaffordable, whether because they don't even know that they got their Medicaid taken away because the state sent the application to the wrong address for re-enrollment, whatever it may be. People are constantly falling between the cracks. 25 million Americans are uninsured. Far more experience on insurance at some point. And this is the kind of thing that I certainly see in the intensive care unit, where people have lapses in coverage, lapses in care, don't see a doctor for years, and lo and behold, come in the throes of some life-threatening illness because they didn't get the care they need. So we got to cover everyone. We need true, universal, seamless is critical, coverage over the life course. So what solutions will address that? And we'll get to that in a second, but that's my first criteria. That has to be met. Number two, we have to deal with the problem of underinsurance. And, depends on how you define it, but the problem is that people have copays, have deductibles, have narrow networks, face insurance barriers, face onerous restrictions on what doctor they can go to, what hospital they can go to, what medication they can go to. So yes, they're uninsured, but no, the insurance is not adequate. No, it's not covering what they need. And that almost applies to everyone when it comes to long-term care until you're impoverished and qualify for Medicaid. So in a way, we have a much larger problem of underinsurance that affects many more Americans than the number uninsured, perhaps most, perhaps in some sense we're all underinsured. So it's a broader problem. And so we have to fix that. And again, that's about financial barriers to care, but it's also about non-financial insurance imposed barriers, now networks and other forms of barriers that get in the way of what you need. And I'll just say that similar to what I said about uninsurance, the underinsurance problem affects a much larger share of Americans than people realize. Because yes, if you survey Americans and say, have you experienced the cost barrier in the last year? Some percentage will say yes, maybe in a minority, right? But if you follow, as we did in a recent study that we published in JAMA IM, if you follow the same people for 4 years, which is what we did, you'll find that every year, even people who didn't have a problem last year might have it next year because they got sick, or might have a problem 2 years from now, might have a problem 3 years now. So the affordability problem is much larger than people recognize and even larger than studies suggest. That's problem number two. Problem number three. We need to achieve savings so that we can do number one and two. We can address uninsurance, we can address underinsurance. So we have to find a way to cut unnecessary spending. And there's two ways to do that: the right way and the wrong way. You can cut spending through Medicaid cuts. You can defund hospitals. A lot of ways to reduce spending on healthcare, right? But it's the wrong way because it harms patients. So we need to reduce spending without harming patients. And there's fewer ways to do that, but two are available. One is we reduce the enormous waste in the private health insurance industry, and that is their overhead, which is maybe around 12% of the total premium dollars, which is about 5-6-fold higher than traditional Medicare. And that is the cost of doing business for private insurers. That's what they need to spend in order to make a return to keep profits. Okay, what is that money going? It's going to things like high executive salaries. It's going to armies of people who are involved in prior authorization and utilization controls. It's marketing, it's product design, it's all these things that you don't actually need, but that they have to do. And I think alongside the administrative waste is the waste of the providers who have to also have their own, billers and coders and people who are involved in this whole process, and that also poses a lot of waste. So the Congressional Budget Office actually estimates if you went to a Medicare for All system, that would generate about $400 billion a year in savings, and then you could use that to do number one and number two: fix uninsurance, fix underinsurance. I think also in line with this, how do you save money safely? Reducing the enormous profits that are taken across the industry. Money that's going into profits and not into care is a diversion of useful resources. So that's the third thing that we need to do. And I would put one fourth thing that I think is important, and that's getting the corporations out of the delivery of care. So, if you were having this discussion 30 years ago, you maybe would only really be focusing on the insurance problem. But nowadays, we have big corporations taking over everything when it comes to the delivery of care, not just the financing of care, right? So the share of hospitals that are owned by for-profit corporations is rising. Hospices are now dominated by for-profit entities and corporations. Dialysis has long been dominated. There's, rising shares of really, in every area of healthcare, private equity taking over the delivery of care. So problem number 4 is rising corporate domination over care delivery. And that's what I want to address as well. That's what we need to address, because we know that corporations care more about the bottom line and less about the patient. And as a consequence, their costs are higher and or their quality is worse. And that's been shown in study after study after study, particularly with private equity, which are these, very short-term, aggressive, sort of hyper-capitalist investors who get in, shake things up, fire a lot of people oftentimes sell off resources like real estate, take the money, distribute it to their investors, and often flip the investment to someone else, leaving the community in the lurch. So I'll leave it there for now, but I want to start by laying out the problems, and I'll just repeat them for the listeners one more time. We need to fix uninsurance. We need to fix underinsurance. We need to achieve savings safely, and we do that through addressing profit and administrative costs. And we need to get the corporations out of the delivery of care. 1, 2, 3, 4. And the question then becomes, what reforms will do that and what would fall short?
Well, Adam, thank you. We've been talking about these issues for 4 years now. Gene, you want to begin with the first question?
That was an outstanding summary of the problem with the U.S. healthcare system. One of the things we're going to talk about today is the public option. I really didn't know much about that till I started looking into it for this session. It's my understanding that the concept of public option is to have the federal government compete with private insurance, and the basis is the competition in medicine will lower cost. Well, I've know a little bit about competition in medicine. This concept that competition in medicine doesn't work goes back to the late 60s and early 70s, where some economists figured out that medicine is not an outlier, that competition in medicine doesn't work. So I want to start with 2 questions. Give us a little idea of what the concept of public option is. And the other question is, does this concept of competition in medicine really work? Does it really decrease the cost?
So the first question, what is public option reform? And I'll start by saying that there are many varieties of this proposal that have been around for a long time. And they broadly defined, it is a public health insurance option, as the name would imply. So a insurance program offered by the government, tax financed, that would operate alongside private health insurance. Now, we already obviously have public insurers, right? We have Medicare and Medicaid being the 2 main ones. I'm going to get to that in a second. So typically what people are envisioning is some new additional public insurer. Now, people have proposed versions of this that range in their scope from very narrow kinds of proposals where it would sort of be one more, say, public option that would be on the Affordable Care Act marketplaces that would, as you said, sort of compete against the other insurers. People have proposed far more expansive versions of this that would cover, for instance, people currently uninsured that employers could put their employees on. And I don't think we need to get bogged down into the sort of fine differences between these, but I think we should talk about kind of what makes them similar, which is that they would continue to sort of operate, as you said, in some sort of competition with private health insurance plans. And I think these options would do different things. Some may have benefits, some would do very little. But I think the reason why they're not the solution to our problems gets back to what you're saying, which is this notion of competition. How would that function? Because that is often how they're defended. It's okay, well, let's keep the private insurers sort of, honest by having this other option out there that sort of, delivers benefits and sort of would make people uninterested in the sort of tactics of an extra cost of private insurance. So why wouldn't that work? And to make the case why I think it wouldn't work, I actually want to talk about a real world example we have of this sort of quote unquote competition in the United States now that is not working, and that is in the Medicare system, right? So if you look at Medicare right now, and I know we're not talking about today's program is not about Medicare Advantage, but it is about public option. And if you look at Medicare, in many ways, the traditional Medicare program is starting to become a sort of public option that is competing with the private insurers in the form of Medicare Advantage, right? So for listeners, you're probably aware Medicare Advantage is the version of traditional Medicare, which was established by 1965 legislation. That is offered by private health insurance companies, that's sold to seniors, and that it's supposed to sort of compete with traditional Medicare. So what has panned out there? Well, very clear what's happened, which is that the insurers have outrun the public system and the regulators one day after another. Since its establishment, they have run circles around regulators and garnered overpayments adding up to hundreds of billions of dollars. And how have they done that? They've played various games. So number one, the Medicare Advantage firms have sought out the less sick, healthier seniors. As a consequence of that, they have less costs, but they still get paid the same, right? So that's what we call favorable selection, or sometimes referred to as lemon dropping or cherry picking, meaning you're trying to angle to get the less sick patients because they're more profitable. The Medicare Advantage insurers have also engaged in something called upcoding, which we won't talk about, but basically making the patients look sicker on paper, which determines their risk-adjusted payments, right? And that was why you risk adjust payments was to try to avoid the first part of favorable selection. But despite those efforts, despite those attempts to hem them in with various regulatory steps, we've seen again and again the Medicare Advantage insurers coming out ahead. And I think that should serve as something of a warning, which might happen with a public option system, that we could see the exact same dynamic play out where the public payer would have sicker patients, have less healthy patients, have higher costs as a result, and then it would appear not so favorable anymore, right? Then it would be losing that competition because it's been outplayed.
Well, Adam, we've done a couple of programs on Medicare Advantage on this radio, and one of the things that I thought was the most remarkable that we've learned in these discussions was Medicare Advantage was initiated by CMS, not by the for-profit insurance companies, which I just was astonished that this as you just described, this terrible system with allowing them to basically bankrupt the Medicare Trust Fund was initiated by CMS.
Well, with congressional action.
Oh yes, but still, the CMS
yeah.
started this program.
Mm-hmm. Yeah, I mean, but I wouldn't say that there wasn't a powerful lobby behind it.
Oh, absolutely, yes. Still,
yeah.
But still, that's where it started. Well, listen. Could you just before we move on, give us a couple of specific examples? I think Washington State has got some kind of very narrow kind of public option. I'm not in favor of public option. I mean, we're promoting Medicare for all, but I think I'd like to have a discussion about some of these issues for our listeners. One of the Democratic individuals running for Senate in Kentucky has expressed that it's in her belief the public option is one of the best ways to deal with some of our dysfunctional system. So that, and this is again, this is someone who was a Democrat who was planning to run for Senate as Senator McConnell stepped down. Anyhow, so if you could give us a few examples, and then we'll move on to something else.
Yes. So when I started off, I said that there's this broad range of public option ideas, and they range from extremely narrow to more expansive proposals. What has been done so far, you referenced Washington State, is these extremely narrow concepts. These are basically, first of all, I believe the one in Washington State is still run by a private health insurance company. It's publicly financed. It has some regulatory, advantages in terms of rules that keep down its payments. But at the end of the day, this is one more plan, one more option that if you go onto the ACA marketplaces, you can choose this one that may or may not have some relatively minor differences from the other plans. So that's how small bore that is. It's hasn't, going back to the framework that I kind of started the conversation with, is it fixing on insurance? Is it fixing under insurance? Is it getting out administrative waste? Is it getting out private corporate care delivery? It's not doing any four of those, not in Washington State, not in other states. So, but yes, that is an example of one of probably the most narrow type of public option proposal, which is a competing plan on the marketplaces that you could purchase instead of other plans for people who do not get their insurance through their employer, through Medicare, through Medicaid, or through the VA. Very small bore. So, I don't think that's the answer right now. And also, I think when it comes to healthcare reform, even from sort of a more political perspective, you do need to do things that help most people, right? So that isn't going to really do anything, even if it is, let's say, somewhat superior to the other plans on that marketplace. And I'm not even sure to what extent that's true, but let's just say it is. Well, how about everyone else? How about people who don't have any plan? How about people who have a high deductible health plan to their employer? How about people who have Medicaid, which has low costs, but doesn't let them see all the doctors and hospitals they need to see? How about someone on Medicare Advantage who has narrow networks? How about, and I can go on. But the point there is that you really need to offer a policy proposal that's going to help the most people. And that's where I think something ambitious like Medicare for All has an advantage, because it's not just, here's this one very narrow group that might find this incrementally better. It's, okay, almost everyone. How could this help?
Well, we're promoting Medicare for all. You live in Massachusetts is a blue state. Kentucky is a very deep red state, and I'm going to make a comment and ask Gene to comment about it. To give you an example, some of the issues we're dealing with, we have a very large population in Kentucky that is on Medicaid, and a lot of rural hospitals that are literally functioning by the skin of their teeth because of their Medicaid populations. And, the issue that I always bang my head against the wall about is for the life of me, I don't understand, is that the Kentucky legislature has a super Republican majority. So the people who are most vulnerable in our state, and this is an issue whether we like it or not, the rest of the country, and I think we want to talk about the likelihood of getting Medicare for all through the legislature. They keep putting people in office who make policy that is against their economic and health interest. The big beautiful bill is going to, assuming it doesn't change in the midterms, which I'm hopeful will have some issue, or some reaction with that. It is going to have a devastating effect on people in rural Kentucky and rural Kentucky hospitals. Now, Gene, I'm a city person. I've never practiced in rural Kentucky, and I don't have an understanding about what's going on in the heads of voters in rural Kentucky. Perhaps you could make a comment about that, and then we'll let Adam make whatever comments he'd like to make about what we've just said.
Well, in our congressional district, about 34% of the population is on Medicaid. And then in our hospital, approximately 73%, it varies, are Medicare and Medicaid. So that restricts our income considerably. It's been estimated based on cost reports from rural hospitals on Medicare data. I think it goes back to 24, that approximately 35 hospitals could close because their margin would be decreased based on the Great Beautiful Bill.
Now, these are 35 hospitals in rural Kentucky.
That's correct.
Okay, thank you.
This is cutback in Medicaid. It's not just going to be in rural hospitals. It's going to really affect safety net hospitals. For example, as we've talked about before, the University of Louisville, when we expanded Medicaid, their no-pay patients went down to 5%. It was previously 20%. If they cut back Medicaid as is proposed, then that's going to affect the universities. University of Louisville has a lot of patients who are on Medicaid. And then, of course, the University of Kentucky has a very large number of patients from Eastern Kentucky who are on Medicare and Medicaid, and they've even purchased a couple of rural hospitals. So decrease in Medicaid is going to profoundly affect medical care in Kentucky. Now, one of the things that we've talked about for a long time is disparitive care, and we're a classic example of how our hospital over the years, in the last 40 years, have changed disparity of care, particularly in cancer care. And we now have a cancer institute that provides a care that can take care of probably about 90% of cancer patients, and we have first-class radiation therapy and chemotherapy and surgery, and we can take care of most of those patients. And then we have an affiliation with the Markey Cancer Center UK, and we work together on very complicated and complex patients. So we have solved that. But if they start cutting back Medicaid again, I'm afraid that that's going to affect what we can do.
Yeah, Adam, I'd like to jump in here to just to give you a sense of how dire it is in Kentucky of that those rural hospitals across the country. I think there's like 338 right now on the list. Kentucky has 35 of them, which for a small state, that's a huge percentage.
Right, right. So, yeah, I mean, I have a few thoughts about, and this is interesting to hear this, directly from people who are seeing it. And what I would say is a few things about the sort of intersection of rural healthcare, the One Big Beautiful Bill, and Medicare for All. So, I think, my focus is not in rural healthcare, certainly not clinically, and I wouldn't claim to be an expert in it when it comes to healthcare policy, but it is near and dear to my heart when I think about, the ramifications of reform. So why is it that hospitals in, rural areas do struggle, and at a disproportionate rate? Why are they at risk of closure? And I think the number one, and how would that be affected by, how could that be ameliorated or addressed by healthcare reform? So the first thing is sort of just obvious, and I think, Gene, you already kind of got to, which is that in the United States, we have disparities in payment based upon people's income, right? So private insurers' payments to hospitals is much higher than Medicare, than Medicaid, typically. There are some exceptions. And so that creates inadequacies of resources based on the wealth of the people and the communities we're talking about. Rural areas, as you said, have higher rates of Medicaid coverage. They have higher rates of Medicare coverage. They have lower rates of private health insurance. They have higher rates, well, at least nationwide, of uninsurance, right? And that's even putting aside the supply issues, the fact that there's going to be less doctors available, that sort of thing. But that's the payer side. More uninsurance and more, and among those who have insurance, the insurance pays less to the providers. So you have this inequity. So, it's what the British epidemiologist and researcher Julian Tudor-Hart, who some people may be familiar with, who's this healthcare thinker and general practitioner, as I said, who did practice, I think, in basically a pretty rural area in Wales, a sort of mining community. He, described this as the inverse care law, that the places that have the greatest health needs, and rural areas actually have higher health needs on average, are often the places that have the least availability of resources. So I think the relative funding shortfalls that are experienced in these communities reflects that inverse care law. So how would Medicare for All help? Well, first off, you wouldn't have uninsured patients, so it wouldn't, that problem will be solved. Second of all, you would have equity in the financing of hospitals, right? It wouldn't be that places that are in poor areas had less resources, because that's not how the payment will be determined. If you use something like global budgets, where sort of the full operating expenditures of the institution were covered, they could save money on administration because they didn't need to engage in per patient billing, and they would have more solidity and more certainty of funding year after year, right? You don't have a drop, in financing one year because of whatever happens. So that sort of continuity and stability in financing, in addition to greater equity in funds, in addition to the elimination of the uninsured problem, is going to translate into protection for rural hospitals. I think alongside that, when you have a national system, you can plan things a little better, right? Currently, even putting aside the issues I've talked about, there's a little bit of anarchical market chaos. And maybe that works okay in some areas where, a coffee shop opens, a coffee shop closes. It's, you feel bad for the owners, but it's not the end of the world. This is kind of how the free market works. We don't want that for healthcare, right? We don't want hospitals opening and closing, disruptions, patients suddenly unable to get care anywhere. We want these to be community institutions that take care of the people there. There's always going to be regionalization. We're not going to be doing heart transplants in the mountains. But but there can be planning so that you actually, people at a regional level, look at the lay of the land, decide the hospitals, certainly the hospitals that we need, ensure stable global budgets year after year, fund those adequately, fund those equitably. So really, Medicare for All would provide a robust toolbox of different policies that would enable us to continue to deliver care in a more stable, fair, and adequate way to rural populations that are currently even without any hospital closures, are currently underserved.
Well, listen, I agree with everything you've said. That's why we're doing these programs. Now, the question is, how do we get that information into the brains of the voters when they go to the polls? Because the big, beautiful bill was passed because there are majorities in the national legislature that allows the same kind of policies nationally as we're dealing with here in red Kentucky. And so that's the problem. I mean, I've been doing this for 4 years, promoting Medicare for All, but I recognize that in this country we've got some issues. So I would very much like to hear your thoughts about how we can penetrate the brains of voters in largely voters in rural America about these issues, so that when they go to the polls, instead of voting for people who are going to put policies that disadvantage them, that they will think about the things that you've just mentioned.
Well, it's interesting because I agree with you. There's a political issue here, and what I would say, the interesting thing, and I'll see if I can pull it up while we're chatting, is in terms of like what the American public believes, is actually very in line with what we're saying. So to be more specific, the One Big Beautiful Bill Act was very unpopular. So when they did and I'm just going to give you one, and I'm going to just pull this up while I'm speaking. So there was a poll from the Kaiser Family Foundation conducted last year, and they asked people about their opinions of the One Big Beautiful Bill, which is going to cut, as people know, about $1 trillion in federal healthcare financing over a decade. And they found that 64% of Americans had an unfavorable view of the legislation. They then gave additional bits of information and then saw how that additional bits of information changed people's assessments. So they then said, okay, well, how about if we told you that this bill would mean that Medicaid spending would be cut by $700 billion. 64% unfavorable view rose to 67%. They then asked, okay, how about if we told you it would increase the number of uninsured by 10 million? 67% unfavorability views rose to 74% unfavorable. They then said, how about if we additionally told you it would reduce hospital funding? 74% unfavorable rating went to 79% unfavorable. So that's just a very, I think, clear example that I think the public does largely agree with us. Obviously, the fact that those unfavorability numbers increased when they provided that information suggests that there's a big role for education, because obviously people were learning new things in the course of that survey that changed their opinion. But 80% unfavorable support. That's not unfavorable support, unfavorable opinion. There's not much in the United States that 80% of people agree on. So that's in a way reassuring. Now, there is the issue of, well, what is the disconnect between Americans' views on these issues and what's actually happening in Washington? But from a public support perspective, we're fortunate to be working in an area that the public actually largely agrees with us, which is not true for every policy area. To give another poll on Medicare for All, this was from Economist and YouGov, conducted last July, and they reported 59% of Americans support Medicare for All. And of that, there's 85% 85% support among Democrats, 57% support among independents, and even Republicans, 34%, right? So 1 out of 3 Republicans supported Medicare for all. So that's not really necessarily, sort of just repeating those numbers is not going to get us to where we need to be. But it does show that public support is at least aligned. Now, I do think, that all being said, to go back to the rural issue, I think there's a critical role for greater engagement and specific focus on rural healthcare issues among all politicians, certainly, but certainly among those of us in the health policy community or who support Medicare for all. I think that needs to be a greater focus.
Well, I am cautiously hopeful that those polls will be demonstrated in the midterms. My wife tells me I am a cockeyed optimist about that, so we'll see what happens. I'd be interested to know what Gene's thoughts about it are, because you live out there in rural Kentucky. Do those people understand those things, Gene?
Some of them do. I think the issue with healthcare is that most people don't think about it until something bad happens. Most people don't plan on having cancer or think about a heart attack and do things that will prevent these issues until it happens, and then it's too late, and then they realize there's a problem. I think that's a big issue. Let me ask you this question, Adam. We spent approximately $5 trillion on healthcare in the U.S. It's about twice as much as any other industrialized country. Will Medicare for all decrease costs? Is it possible to go to Medicare for all without increasing taxes?
So when you talk about healthcare financing and the health and the economic implications of Medicare for all, there's 2 separate questions. One is, what does the federal government spend on healthcare? And 2 is, what do Americans spend on healthcare? Okay. So the more important question from the affordability perspective is, what do we all spend on healthcare overall, right? Because that's the more important question, right? It's not, if I'm spending more and more and more of my money and giving it to United Healthcare every year, like, that doesn't make healthcare more affordable. It's just that it's going to a private payer. Okay. So what I can tell you is about the economic implications of this. The best economic analysis comes from the Congressional Budget Office, which is sort of Congress's sort of nonpartisan analytic arm, scorekeeper, as it's sometimes referred to as. What they find is, as I said earlier, that the biggest savings for Medicare for all is on the payer side. So a simpler system of administering healthcare, of paying for healthcare, they estimate would be $400 billion annually in savings, and that is more than enough money to eliminate uninsurance, to eliminate underinsurance, to cover all of us, right? So that is the takeaway. I think you could spend similar or less money, somewhat less money, with Medicare for all and still achieve the things we want to do. Now, to do that, currently about 2/3 of all healthcare spending is already going through the government. So if you add up Medicaid, Medicare, Department of Defense, VA, the public subsidization of private health insurance, which happens through the tax subsidies, through the ACA, various things. If you add up all of that public spending and subsidization of private health insurance, it's about 2/3 of total healthcare dollars now, already, pre-Medicare for all. So you would need to cover the remaining third, or most of it, with taxes, okay? That being said, from the perspective of the individual patient, citizen, person, they're not going to see an increase in cost. They're going to see similar or less overall money flowing through the Medicare for All system. And this could happen very seamlessly, right? So let's say one financing mechanism, they probably need a mix of taxes, but one of it would be employers would continue spending either all or some of what they're currently spending on healthcare, but rather than having that money go through the private insurers who are then going to keep 12% of it for themselves, have it go directly to Medicare for All, right? From my perspective, that money was never coming to me to begin with. It was already going to whatever my private health insurance is, United or Aetna, whatever. And now it's going more efficiently and maybe a little less, giving my employer a saving, to Medicare for All, right? So I'm not saying that's the way you have to do it. There's different proposals that have been sort of articulated or outlined that could fund Medicare for All, but that would be one way you could do it. That wouldn't have any disruption. And again, the most important thing at the end of the day is, what are patients seeing? At the end of the day, not is the money going to Medicare for All versus United Health? It's what is my total costs, right? And so from the patient perspective, you'd be getting rid of copays, you'd be getting rid of deductibles, you would be allowing them to see any doctor, you'd be getting rid of out-of-network surprise medical billing, and yes, you'd be doing things to lower the overall cost of care on a national level as well. But from the patient's perspective, the costs would fall even if a greater share of those dollars was being routed through Medicare for All instead of through the extractive, wasteful private health insurance industry.
Again, I agree with everything you've said. Let's hope that gets into the heads of the voters. Let's talk a little bit about Medicare debt. I'm sorry, bank medical debt, because that's the main cause of bankruptcy in this country. And we've done a program on that. And if you go looking at other first world countries that have national health insurance programs, it doesn't exist. We are literally, I think, the only first world country in the world that has issues with medical debt and medical bankruptcy. Gene, you were going to say something. I'm sorry, I didn't mean to interrupt you.
Let's talk about medical debt. And I've got an interesting question about what would corporations, a big corporation, or even small companies that provide health insurance, they would save a lot of money of not having to pay for insurance. That's one of their biggest expenses. What do you think would happen with that? And why wouldn't private industry want to get rid of paying the bill for the health insurance?
Right. So why wouldn't employers prefer to have Medicare for All so that they could see their payroll costs go down, basically?
Right.
Yeah. Yeah. I mean, I don't know how employers will react. I can't predict. I do think that there could be benefits for employers in terms of their healthcare costs being more stable, being something they can really get out of the business of altogether, not something they're administering, not something they're dealing with, not something that a competitor can undercut them by offering worse, benefits. So we'll have to see. Now it may be that, some corporations don't love that you're going after another big corporation, the health insurance industry, and sort of exhibit some solidarity on that front, even if they could benefit in their own way. I don't know. It's not the world I inhabit, but I do think that there are benefits from a business and from a entrepreneurial perspective, particularly for smaller employers where healthcare costs could really make it impossible to hire new workers in some cases. But also for larger, for larger employers as well. Because at the end of the day, as I said earlier, we do need to achieve some savings, and we can, but it does have to be through a publicly administered plan that's going to get rid of most of that 12% of administration and profit waste.
Well, I've said this before on this program. About 20 years ago, there was a general surgeon in Louisville who had some visual issues, and he had to retire from clinical practice. And he ran for public office and was elected to the Kentucky House of Representatives in one of the eastern Louisville districts. He gave a talk about 20 years ago at the Louisville Surgical Society. And he made, and this is one of the issues that I keep harping on that we're dealing with, he made two very important points. One, something that we've all heard before, that making laws is like making sausage. And the other thing, as a physician who had become a politician, he was very, very, very clear that the politicians don't understand healthcare. They're lawyers. They run road construction companies. They have grocery store chains. Multiple things. They're accountants, and the complexities and the issues that we have been discussing, and that you have rightly pointed out, Adam, are important to improve healthcare in this country. They simply don't understand. And I don't know how we can deal with that, because we're looking at, with the big beautiful bill was an extension of tax cuts for the very rich and corporations, funded by by defunding Medicaid. Paul wants to.
Yeah, Adam, I listened to your recent talk from National Single Payer. And something that you touched upon that really caught my attention was the fact of the question is, how do we make all this happen? And you mentioned a strong mass movement from the population. And I tend to think you're absolutely right, and I think that may be the primary driver, and we're not capturing that attention from the people. And so what's your thoughts on how we do that? How do we mobilize the public?
There's no one thing. It's a movement. It's a campaign, and it's not just the physicians. It's not just other specific groups. It is a broad coalition of parties and of advocates and of Americans working together to achieve something that is a huge lift. Now, that being said, there was progress on this issue. When I think of how I got involved in Medicare for All advocacy, when I first started, I was a resident in New York City. And it really felt like very pie in the sky. It wasn't really a part of the national political discourse. Bernie Sanders' single payer bill, he was the only person on it. Okay, there was a House bill with more co-sponsors, but not all that many. And really, in the course of several years leading up to the pandemic, there was a lot of growth and political activation, majority support seen in polls. I forget how many. The Senate bill that Bernie introduced had, I forget, 16 or 17 co-sponsors. When was that? 2019, maybe 2018. The House bill shot up. 2/3 of the House Democratic Caucus got behind it. I'm not trying to claim it was it was about to happen, but what I'm saying is progress was made. There was awareness of the general popular in the general popular imagination and coverage, and things slid, with the pandemic and with a variety of other political shifts. It slid off of the front burner to the back burner. But I think we are entering an area where that's going to reverse. We're entering a moment when that's going to reverse. You're already seeing it. You're already seeing more and more people talking about Medicare for All in political campaigns. You're seeing healthcare emerging to the forefront of Americans' concerns about affordability. I went through some of the polls on the Big One Big Beautiful Bill, on the Medicare for All. These are issues that are among the highest concern in the general populace. I forget, I don't have the survey in front of me and I won't dig for it, but I forget who it was. I think it was Kaiser Family. KFF did a concern like, what was your most leading cost concern. I think healthcare was number two. So it's growing and it's emerging as a leading issue. The question is what happens next, and that's kind of up to us. From my perspective, a lot of the work I've done has been in education in the physician community. That's important, but no one thinks that's the end of it, right? I think no one's done I don't think there's any very recent polls of physicians, but there has been a growth of support for Medicare for all in the physician community, which is important, with some polls showing majority support. I think there's more work in that arena. Certainly there's been support from National Nurses United and the leading nursing union in the country, but there needs to be movement in all the other civil society organizations and organizations, and that's kind of our work. So I wish I had an easy answer, but it's going to be a big campaign and a big coalition.
Okay, Adam, Gene, we're down to about 2 minutes here. I want to thank you very much for coming on. This has really been an interesting program, and I'm very hopeful that what you've said will penetrate the brains of our listeners. We'll give you an opportunity to make a few quick comments, and then Paul's going to take us out.
Well, I've said a whole lot. I really appreciated the discussion, and I look forward in particular to more discussions on the rural angle of all of this, which I think needs more attention.
All right. Again, thank you so much for tuning in and with us and sharing your tremendous knowledge of this subject that is near and dear to our hearts. I assure you. And thanks, listeners, for tuning in also. So everybody, have a wonderful rest of your day.